Sue Elliott. I'm the Service Improvement Lead at Central Manchester, and I'm going to be speaking to you today about the Productive Operating Theatre programme. It's by no means my story, it's a lot of people's work that I'm presenting today, some of who I've been able to invite with us. So if any of you want to talk to the teams, they are here for the evening. This presentation really is the story that we've been working on the Productive Operating Theatre for 3 years. And what we wanted to share with you is the way that we've managed to do large-scale change using a franchise approach, so that 48 theatres are now doing the TOPT programme. But it is, as with all productives, based on a house, based on modules, based on a box set. And we were lucky to be chosen to be an associate test site back in 2009. So we started the programme with a picture of a house, but no box set. And we were able to work on things with our theatre staff based on what they believed should be changed. Central Manchester, just for your information, is a large university trust in Manchester, and it's made up of 6 hospitals. We've got 48 theatres altogether, and we do about 140,000 operations a year. So the task was big, but we started small, and we started with a single specialty theatre with a set of objectives in 2009, which were obvious ones, really: to improve patient experience, to improve safety and reliability, productivity and efficiency, and cost effectiveness. And we had one around staff engagement, which to begin with was around engagement with the programme. And as time went on, we built in a 6th objective, because we realised that actually what we needed to do was change the whole trust. We needed to change attitudes to theatre staff, and we need to change the attitudes of theatre staff to the trust. So very quickly, what we achieved, because I'm sure you'll be interested, we reduced errors through improved communication, and I'll give you a bit more detail about that in a minute. We reduced risk of infection through our storerooms. We had, well, to date, about £500,000 worth of reimbursements and contract savings that have been achieved in the last 2 years. We reduced time spent searching by 85%. We improved utilisation by 10% and start times by 20% in theatres that we're working in. But I want the theatre staff to tell you the story a little bit, so I'm just going to play you this.
Before TOPT arrived, theatre was disorganised, a bit chaotic really. Nobody really knew where anything should be, overstocked, too much of one thing, not enough of another. And if you went somewhere, you didn't know whether you were going to find the piece of equipment you wanted, or indeed any of the stores that you needed.
Before TOPT arrived, stock was kept in different places, and it wasn't particularly organised into specialities. Sometimes it was the stock was kept downstairs, but most of the people needed it upstairs, so that meant that there was a lot of travelling and carrying things between the 2 theatres. The ordering of all the stock was a very ad hoc system. We didn't really have any particular person that we could go to organise the ordering of the stock. We used to do it. The stores were organised into specialities, and then this was colour-coded and clearly labelled. So whereas before you'd go into the storeroom, you'd be looking all over the place, and then you'd be spending so much time trying to find the equipment and wasting time. Now that you could pretty much go to the place and find it quite quickly. I asked people in the department how they feel about TOPT and if it's improved, and everybody says that they feel it's much more organised. They like the idea that they can go into the storeroom and they know exactly where they can find things, and that they've got somebody who they can go to make sure that that we're not running out of stock.
TOPT Forum works very well because it gives me a way of communicating, see what's happening with the rest of the trust, and therefore we know where we're up to with other theatres as well and what we should be doing, and making sure we're all in line.
But from the forum, because there's different hospitals coming together and explaining their experience, it makes you realise that it's not just our department have these problems, it's a similar thing, and they give, and we share ideas. For example, we were looking up at a standard operational procedure for the first 30 minutes of in theatre to get the patient sent for, and so I adopted. I used the framework that the Children's Hospital had used because they had introduced it first and it seemed to work, so we've tried to incorporate that into ours as well.
Looking back now, over the 2-3 years that it's been, I think the major thing was that it gave staff empowerment. It made them believe and want to belong to making the changes. We all knew there were problems and we identified what the problems were. What we didn't know is how to change them. And what TOPT's done, it's give us the information and the tools to be able to make the changes and to make that they're sustainable for us all to work with, which has made it a better place for us to work and a better environment for our patients to come into.
So hopefully that's given you a flavour of the teams and how they think of TOPT and how, you know, in terms of large-scale spread and sustainability over the 3 years, we have got that level of engagement. What I wanted to do, we could have told you so much of what we actually did, but I wanted to briefly take you through the story, and there'll be plenty more things you might want to ask at the end. We started in a single specialty theatre, and that was our pilot area when we were an associate test site, as I said at the start, and that was the gynae theatres. We then moved on to a multi-specialty theatre, so they were all children, but it was every specialty for children, to see if we could scale up and repeat what we'd already done, which we discovered we could repeat principles, but not necessarily the same thing. We then spread to the adult theatres, which was a bigger task altogether. It was 14 theatres over 2 floors in 3 different parts of the hospital. And then we thought, well, how can we get all 48 theatres in all 6 hospitals doing this? At the pace we were going, it was quite hard. So we set up a TOPT forum, which is referred to in the film. So I'll take you briefly through some of that. In St Mary's Theatre, our pilot area, we worked initially on the foundation modules, and we worked with theatre staff figuring out what would be the data, what was the available data, what was the data we needed to get that wasn't currently available, how did it need to be presented so that people actually understood it and wanted to look at it and use it, what did the data definitions need to be so that everybody was talking the same language, and some of that was hard because we had some people vandalising the board because we had put induction of anaesthetic instead of start of anaesthetic, so all that learning was going on in that one theatre. We did 5S work as part of well-organised theatre, and the theatre staff said, well, it'd be really good to use visualisation and have colour-coded sections, because then we don't have to go to every bit of the story, and we only have to go to one bit. So again, a good idea. We did status at a glance boards in that theatre. We did name allocation boards, which was a straightforward piece of work. We tried mini boards outside the theatre where you could have a traffic light system to say if the list was running to time or if there was delays. And we learnt the concepts of status at a glance within a theatre environment. Team brief and debrief, I'm going to tell you a bit more about that in a minute, but that was the first thing we actually changed in that theatre. And so we've got some interesting information about how that one change made significant differences and then how we rolled it out. And then obviously we did some shared mapping events. So we moved from that, working with theatre staff and saying to them, you are owning this department, it's your department, you're here day in, day out. Everybody else is a visitor, so they have to wait for their voice to be heard, but for now, it's about you working out what you want to do every single day. Then you work with your partners. So your partners might be the surgeons, they might be the anaesthetists, they might be the admin clerks, they might be the ward staff, and so we did partnered mapping events with the relevant people. So I'll briefly tell you the team brief story. In St Mary's, you just see on the left there, they were in an old theatre suite to begin with. And we started the work and then we moved, which was all a bit like, why are we doing it now? Because we're going to be moving. But it actually helped with the move. So the environments look better. But before we did team brief, theatre staff communicated at the start of a list if they were lucky enough to find somebody who wasn't busy at the point when they remembered what they were supposed to be saying. So it was very ad hoc. So the team set up what they thought was the right structure for a team brief, who should be there, standardised that and agreed that they would do a debrief as well to learn lessons. So afterwards they had, as a minimum, they had the theatre practitioner, scrub practitioner, anaesthetic practitioner, and then ideally the recovery practitioner as well. They had a surgeon, they had an anaesthetist, and then sometimes even a porter, and hopefully everybody was going to be in the theatre. But we set a minimum number of people that had to attend the team brief. And they went through a set number of things to pass on, and then they had a debrief at the end that said, well, actually now we've done the list, we've realised that you never told us this and you should have told us this, and so in future can you tell us this? And that's where the learning came in. So throughout that period we asked them to collect data, and one of the bits of data they were collecting was around glitches. So what were they learning in the debrief about things that could have been different? And the main one was equipment. So what they found was a surgeon might put on the list, Mrs. So-and-so needs this procedure, plus or minus, whatever. And sometimes the plus or minus query wasn't even the detail of the procedure. And what the surgeons didn't realise was that that plus or minus procedure required equipment that was stored down the corridor that actually somebody else might be using, which meant the list order had to be changed or the patient had to be cancelled, or there was a delay to the start of the list. And so that was their main issue. With that in mind, surgeons and anaesthetists learnt to list differently. They learnt to inform staff a week early for things that had to be ordered. They learnt things, but as did theatre staff, and they learnt to have things ready because that was what they always wanted. So with that simple learning process, in 3 months they eliminated equipment errors and have sustained it. We also did staff questionnaires about attitudes to safety, and we predicted, based on the questionnaire, that the categories that we would improve would be teamwork, safety and possibly job satisfaction. We did the survey before and after, and as I said before, this was the only change we'd made at this point. We produced the graph and we thought, it's better than we thought. It's done even more than we thought it would do. Everything's improved pretty much. So then we did an unpaired t-test and we did statistical analysis to see if actually we had made those improvements. And the only 3 that were statistically significant were the 3 that we predicted based on the change that we'd made. So with that in mind, we could then go to our trust-wide clinical effectiveness committee and the steering group that were working on the WHO checklist. And we said, actually, the work in this one theatre has all this evidence as to the benefits of it. Can we start to work with you on how it's done trust-wide? So we came up with a status at a glance board that was patient level, and that supports the team brief. It has a traffic light system, so if there's no equipment, what's the point in sending for the patient? So there'll be a red dot, don't send for the patient. And that then supports a standardised team brief leading into the sign-in, time-out, sign-out. And all 48 theatres do this. So whether they've done the programme or not, this is just the trust standard that we rolled out. So after our initial learning, we moved on to the children's theatre and we said, can we scale it up? Can we spread it? What can we do the same? What do we have to do differently? And when we got to their theatre storerooms, they were much bigger. It was a bigger job. We're like, how do we do this? And what we knew straight away is we couldn't do it on our own. So we immediately started partnering with materials management and procurement. So we didn't just have the theatre staff because they were often busy, so we couldn't always release them at the time when we needed them. But we, one way or another, got their input at the right time. We got manpower from other places and we worked closely with other corporate partners. We planned it very carefully, and then we said, right, we'll start this day and we'll be finished in 12 weeks and we won't do anything else then, we'll have finished it. So we had a very clear plan of what we were delivering on, and the way we did it, we removed overstock based on what theatre staff. So we'd say, do you really need 70 boxes of Gamgee? Once we'd found them all around the place. And they go, well, we don't really use it anymore. So, you know, we got rid of it. But then if they said, oh no, we absolutely need it, we say, oh, okay, well, you can keep it, but can we get rid of some of it and just see how you go? And we'll put it round the corner and you can still get it if you want it. So in that initial overstock phase, we were able to pull out a lot of overstock to make way for making changes. And then we said, if materials management work with you over a period of time, we won't rush you, can you then figure out more savings over the year? So, before we had lots of overstock on the shelving, once we'd put the shelving in, Afterwards, we didn't have that overstock. We numbered all the columns, we lettered all the drawers. Materials management took over with a cataloguing and barcoding system based on the shape of the room, and we colour-coded all the sections. So staff could go in and they could say, OK, I'm working on the orthopaedic list today, I only need to go to the blue section. When they got there, if they couldn't find what they were looking for, there was an alphabetical list that would say this item is in column number 1, drawer number B, and so on. We also found that some people called the implement by its actual name, some people called it by their cute name. The surgeon might call it by the, you know, that thing that I want, and then that was what it was called. So we'd put all the different versions of the name of the item in the alphabetical list, but the label was just a generic label. So with that work in that theatre, we had 126,000 reimbursed just to the overstock that we removed, that the theatre staff was saying, actually we don't need that. We evidenced time spent searching by asking 5 people before to go and find 5 items, timed how long it took, and then did the same again afterwards. And we reduced the time spent searching by 85%, just with labels and alphabetical lists, really. And we reduced the risk of infection. We had air quality testing done in the storeroom before and after, and we had an issue before with a number of bacteria floating about, and afterwards it was as clean as in the actual operating theatre itself. So then that led us on to thinking, can we roll this out quicker? It's taken us a long time. We were finding each theatre, it was at least a year of intensive work to get people ready, engaged, planned, do the storing work to prove that we would actually be able to do something, to get them to the point of going, actually you can do some work with us because now we believe you can. And then 6 months later we'd be moved on. So we had an issue and we had 48 theatres to do. So we thought, well, we need to think about this differently, and we came up with this franchise approach, which was to say, we know theatre staff like the data presented by like this. So actually you're all getting it like that. But that's no good unless you look at it. So we're going to produce TV schedules of your list week by week. We're going to produce performance dashboards week by week. And we want you to have a multi-professional group looking at the data and actually using it to make decisions and analysing it. We wanted the colour coding everywhere so that materials management could go and find where to put their stock in every theatre and it wouldn't be confusing. And we'd already done the WHO checklist with our status at a glance boards. So we felt that we had the beginnings of a franchise. And what I mean by a franchise is, if you think about McDonald's as a franchise, anywhere in the world you can walk in and you can see if that's as good a McDonald's as the one you went to previously, because they're supposed to look similar. And we wanted to be able to do that. We wanted to go to any theatre and know the TOPT programme is happening, we want to see it at a glance, we want to know if it's to the right standard, and we don't want to be spending ages. We needed to think lean as well. But they had to own it. They had to be the business owner of their own franchise, or else it wouldn't work. If it was always us saying do this, they would never actually do it. And so that's why we came up with this concept. So with that in mind, we were moved on, again, 18 months after the children's started, to our adult theatres, which, as I said before, was over 2 floors in 3 different places. Massive project. The storerooms weren't the new hospital bit, so they weren't nice storerooms. They were really tiny little storerooms in very strange shapes with these big columns stuck in the middle of them and that kind of thing. And they'd been, over time, building up their own way of doing this. So if any of you have been in a theatre storeroom, often looking like this, piled up with cardboard boxes. They had their own system of ordering, so they bulk buy because it's a bargain, but then they can't get through it, so it's out of stock. By which time you're shoving it in every corner you can find and nobody can get in the room and nobody knows what's there, so you just order it again. So we had a painful process, which, as Tracy said in the film, we had to get stuff that was being stored downstairs upstairs, because that's where it was used, and vice versa. We had to completely rearrange it so that it made sense, and we said, well, we'll put some colour codes up for now, so that you can see at a glance if you've got ridiculous things in this room. So we allocated a room to be an anaesthetic stock room, and if anything wasn't a yellow label, well, it couldn't stay in the room. So we kind of used the system to help us get that job done in a 12-week period. We did recruit lots of manpower for that, to be fair. We had 25 people for the month of September in total. coming in and going out over the period. So we always had at least 5 people every single day moving stock around on that phase of the 12 weeks. We haven't got that many people in our team, I just need to mention. And we partnered not only with materials management, but with NHS supply chain as well. So they provided us with lots of people and made it a team away day for people. In that 12 weeks, we got 140,000 reimbursed to them due to their obvious overstock. They did have waste, so we did have to say, actually, you can't count it as a reimbursement because it's out of date, so you've just wasted it. And then, over the period of time after that, materials management, with their work, were able to reset contracts because they were taking on the role of ordering for all the theatres. So they can negotiate better contracts, they could switch suppliers, they could make it work for us as an organisation. And so in the first adding up of what we did in the first year, they had about 125,000 per annum saved in recurrent costs because that was around their changing in contracts and also around delivery costs. If you're only getting 1 delivery from that supplier instead of 6 deliveries to all the theatres, then you're not paying as many delivery costs. So how was the franchise approach working? It was allowing us to spread at a slightly different pace, but the work wasn't quite as intense. Were we supporting areas to sustain after we left them and progress? And that was the issue, because we were worried about that. And we found that, yes, they were sustaining the work we'd done, but no, they weren't necessarily progressing. And how could we carry on onto new areas that had had no input from us without any facilitator time? Because by then, we weren't just doing the theatre project, we were doing the ward projects, the ward accreditations, the dementia, the end of life, everything by then. So we had 3 things that were part of our franchise thinking. One which was we need strong partnerships at corporate level. So clearly the materials management and procurement was one. We had information teams working with us and developing the dashboard so that wards could log on, choose their ward, choose their surgeon, right down to surgeon level to see activity, or they could see the trust level activity. We had clear standards, the 4 that I've described to you, and we'd set the branding of what TOPT looked like. But then we set up the TOPT forum as well. And we said, what we'll do is we'll trial it out. We've done it for a year now and people want it to continue. But we would use that as a method of teaching, the tools and techniques. We'd use it as a method of sharing, so people sharing back to us so we can give guidance and advice, but also with each other, good ideas. And peer support. For the first time, we had a forum where theatre staff came from every theatre in a room together and spoke to each other. Because traditionally, theatre staff stay in theatre, nobody dares go in because you might touch something you're not meant to touch, and nobody bothers to come out because why would you bother? You don't need to. So there'd been that distance, and that's where this cultural change that we needed to bring across the trust came into our thinking more and more. Within the TOPT forum, we were able then to share good ideas. So as Tracy in the film said, she's doing session startup, and the whole forum are doing that. But we took the work from Children's Theatre. So they'd done some work themselves, and you can see here that they introduced the standard operating procedure at this point on these graphs and had a very clear improvement in the percentage of lists that started on time and the amount of time that they saved overall in that period of time. It worked because they designed the standard operating procedure and they committed personally to making it work. So we took the standard operating procedure, which says the first 30 minutes of the day, who does what and when they do it and who talks to who and when, to the forum. And people said, well, if that's the standard, I would only need to tweak the times, or I would only need to say, well, actually, for us, recovery do that, not the anaesthetic practitioner. So they'd tweak it slightly, but that now is part of the branding. So everybody's trialling it, and they're all using a standard method of measuring it. So we're measuring all the theatres at the same time in the same way, and that's current work. So where are we now in our objectives? Patient experience is always hard to measure for theatres. So we haven't got data yet, but we have added questions about theatre to our patient questionnaires at ward level. So we've got 6 months' worth of data that we're about to collate into our dashboards. Safety and reliability, cost effectiveness, productivity and efficiency, I've gone through a fair bit of that already today. But as far as staff engagement, we've definitely got staff engagement with the TOPT programme, with the people that come to the forum and a few others that have been involved. We've got staff engagement in 5S, because they love the storerooms, but TOPT's more than just 5S. But actually we're more interested in, have we got staff engagement with the rest of the trust? Have we got something now that means that theatres are not separate anymore, that theatre staff get involved and that we remember to invite them? You know, it's a two-way process. And I can tell you that we have significantly changed that. And you can ask the teams. We've got Hilary, theatre matron, we've got Julie, theatre practitioner. They'll be able to tell you. But this is one of our other projects, Harm-Free Care, and we were launching balloons to start that project off. And the majority of the staff there are from wards. Previous to the work we've been doing, that would have just been ward staff. But now, on the front row, in the absolute limelight, are the theatre staff that attended the event. Because they want to be part of everything. They don't want to be separate anymore. And we want them to be part of everything as well, because it was wrong that they were separate in the first place. So, what do staff think now? Deborah Carter, who's our Deputy Director of Nursing, admits that they're often thought of as the Cinderella of trust business theatres, often forgotten about because there's no patient questionnaires about theatres, so we're not held to account by national targets. And through doing the work, we've liberated untapped talent and efficiencies. Efficiencies are really good, and we all want to do that, but actually it's much more important that we change people and attitudes. Julie, as a recovery sister, talks about TOPT as being enabling staff to have a voice. It was not that they didn't know the issues, it was that they didn't know how to fix it. And that enabled them to make changes that they knew that they wanted to make for patients. Hilary refers to the wider context and about that, how understanding the wider context, theatre staff can now understand the direct impact on patients. And that's really important. Tracy, as a scrub practitioner, had the dawning realisation that things don't change overnight. It does take a long time, but actually continuous improvement, ongoing processes are what we need to do. We don't need to give up, we don't need to get downhearted. And by having a product to support that, it really does make a difference to them being able to ask for things to change. And then Mark, from Materials Management and Procurement teams, said, actually for them, without TOPT, they wouldn't have been able to engage with clinical staff like they do. It's been able to bridge the gap, give a common language, and allow them to work in partnership with theatre staff. And we now are not involved in that. We don't need to be as a service improvement team. It's just normal business now. So what's next? We've talked a lot about performance, and we've set up performance dashboards. I've got copies of them near our stand if anybody wants to see the actual dashboards and what they look like and the TV schedules. But we're working towards a quality dashboard because it isn't just about performance, it is about quality. So we've got the TOPT forum running away with teaching theatre staff how to make changes, but then we've also got a matrons forum. And the matrons are focusing on quality, so they're focusing on how do they do quality care rounds in the way that the wards do, so that they're looking at cleanliness, infection control, staff satisfaction, patient satisfaction in the whole picture, not just efficiencies. And with that, we're setting up the quality care dashboards, which the wards already have, and that's where our patient experience feedback will go back to theatre in that dashboard. And then for 2014 onwards, staff have asked that they become part of the Improving Quality programme as a whole, which actually means an accreditation process. So the wards all get accredited as to whether they're bronze, silver or gold, and the theatres from 2014 will have teams of directors of nursing and ourselves going in on a regular basis and inspecting for a 4-hour period and allocating them a bronze, silver or gold award. So hopefully I've not left too many unanswered questions, but thank you for listening and I'm happy to take your questions. If anybody's got any.